morning. It's a little interesting for me as a big-time University of Michigan fan to introduce our next speaker. Dr. Hana Choe is an assistant professor currently at The Ohio State University Comprehensive Cancer Center in Columbus. Dr. Choe received her Doctor of Medicine from Indiana University School of Medicine, and then went on to complete internship and residency in internal medicine at the University of Southern California. Her fellowship was then in hematology and medical oncology at the Weill Cornell Medical Center in New York. She is currently the director of the Ohio State University GVHD program. This program is really dedicated to research and provision of complex care and coordination of acute and chronic graft versus host disease patients. Her title of the talk today is Knowledge Check, Liver Graft versus Host Disease. Dr. Choe?
Sounds like I might not have my slides loaded. So I might have to wait a minute for that. Should we just go ahead? I should just wait for the slides, right? Just wait for the slides to, because otherwise the virtual attendees can't see anything. They said they didn't have them, but I sent them. She doesn't. No, I have a flash packet. Oh, okay. That's true. Yeah. I bring it through the speaker slides. The liver GVHD one. Should be good. Yeah. Unfortunately, we can't hook up to the actual laptop. So that was the other problem. We have to have it loaded at first because it's through Zoom. Yeah. Okay, great. That was pretty quick. Thank you very much for fixing that. So thank you very much for the introduction, Ken. It is an honor to be here amongst dedicated researchers with a common goal. To better understand the complexities of chronic GVHD, this is very niche. This is a very special community, and it's great to be part of it and to be in person with you all. So one outstanding complexity that we're going to be talking about today is the enigmatic liver. So when I was first asked to give this presentation, the goal was to raise awareness about liver GVHD. At first, I thought my disclosure should be that I'm not a hepatologist. And then Steve Pavletic recommended that I talk to Theo Heller, who is a hepatologist at the NIH. And his first disclosure to me was, I'm not a transplant physician. And so then I was getting ready for this presentation, doing a lot of research, putting together papers from all the liver GVHD research that's really out there that can be honed into this basically overview of liver GVHD, and found that it's mostly from pathologists. So now my first disclosure is I'm not a pathologist. But this speaks to the multiple disciplines that we need to be able to diagnose and treat liver GVHD, the different subspecialty and knowledge base that we have to have. So we'll talk about how liver GVHD in particular is misunderstood. It's often taken for granted, often ignored, and it's really the black sheep of chronic GVHD in many ways. So this is, but this is not from lack of being visible, right? So we all know what liver GVHD is. And in fact, previous reports of the cumulative incidence of it in single centers may have been small, acute GVHD and liver involvement 6.7 to 15.7%. For chronic liver GVHD, might be 5.8 to 31%. But when you look at it, sorry, where am I advancing? Sorry, where am I advancing? How am I advancing the slide here? Oh, here it is. But when you look at a CIBMTR analysis that's actually looked at liver GVHD over the years, you actually you see that it's made up 45 to 49% of in any case of chronic GVHD at maximal severity. So it's very much high prevalence within the community of patients that we treat. So clinically, liver GVHD in general appears anywhere between 2 months to 2 years after stem cell transplantation. And this has been described since the first series of GVHD biopsies was reported in 1977. Nothing much has really changed in that amount of time. And back in 1984, they were already describing that up to 75% of all patients might have some component of liver GVHD. It's typically presented with a cholestatic picture, but it could be hepatitic, and we'll describe what the difference between those two are here. And then there's no diagnostic imaging findings, unfortunately, that we can lean on to help us when we're trying to diagnose liver involvement. So as I've mentioned, there's acute liver GVHD and there's chronic liver GVHD, and then there's hepatic GVHD and classic GVHD. Publications are muddled then also by the use of the old distinction for acute GVHD, which used to be less than 100 days post-transplant, and now more savvy. We know that it doesn't matter how many days necessarily, it's about the presentation and the pathophysiology of what's occurring. But when you compare hepatitic versus classic variant graft versus host disease with the NIH consensus criteria, the pathology working group has, updated that from 2004 to 2014, and their definition of acute graft versus host disease overlaps with hepatitic. And when inputting the clinical observations with these histopathologic findings, the hepatitic variant correlates with AST, ALT elevations, tapering immunosuppression, following presentation after a donor lymphocyte infusion. This would be consistent with a more acute graft versus host disease presentation. Whereas the classic variant tends to have a more chronic, slowly progressive clinical presentation with slow increase of ALT, alkaline phosphatase, GGT, and total bilirubin. It also makes sense that with a more acute presentation, you see an influx of activated T cells causing lobular and portal inflammation, and not yet with any fibrosis as seen more commonly with chronic liver GVHD. And so these blues tend to mold together and the reds tend to mold together with the acute versus the chronic. Here are the NIH consensus minimum diagnostic criteria, which, by the way, were not changed again from 2004 to 2014. So unfortunately, not a lot has changed with the diagnosis, with nuances of the diagnosis in our knowledge base from that point of view. So this is an example of what pathology might look like in the range that you're seeing within liver GVHD. This is all liver GVHD technically, but what stage of liver GVHD or what presentation of liver GVHD. So figure A is a classic example from that pathology working group of a late onset acute liver GVHD. Destroyed bile ducts, infiltration of lymphocytes, vacuolization of the cytoplasm. Figure B, refractory chronic graft versus host disease technically by clinical diagnosis with withering bile ducts, nuclear dropout, and enlargement of the nucleus and infiltrating lymphocytes as well. And then figure C, a case of refractory untreated chronic graft versus host disease with complete lack of bile ducts lymphoplasmacytic infiltrate, and bridging fibrosis. So a lot of heterogeneity, even within liver graft versus host disease and all from a liver biopsy. So when you review the biopsies first and then correlate to the clinical characteristics, what do you see? Instead of the classic obtaining labs and then deciding to pursue a biopsy. So pathologists at USC published their assessment of this in 2022. They had 50 liver biopsies from 40 different patients, and they reviewed and classified them as either hepatic or classic. 30% of these cases were hepatic variants, 70% of them were classic variants. Interestingly, while 87% of the cases in the hepatic cohort were over 100 days, patients were significantly seen more commonly in the setting of taper of the immunosuppression on tacrolimus or sirolimus. And there were patients that were also noted to have a longer time to recovery and normalization of their liver enzymes and transaminases even with treatment. It was similarly 83% in the classic variant cohort that were also over 180 days. And again, this is the problem with some of these papers, is that we're using this classic 100-day cutoff, which muddles it. It still could have been acute, still could have been chronic. We don't know. The only statistically significant laboratory difference from those listed between hepatic and classic variants was that AST was more elevated in the hepatic variant. And then you did see a trend towards higher total bilirubin in the classic variant, but this was not significant. Cholestasis was also noted a little bit more in the classic variant, 40% of cases versus 20% hepatic cases. But again, no classification of acute or chronic here. So now that we know about the different kinds of liver GVHD, what does that translate into in terms of clinical outcomes? So interestingly, liver involvement in acute versus chronic GVHD has significantly divergent implications. In an old study of 142 patients with acute GVHD, initial liver involvement increased the risk of non-relapse mortality with a hazard ratio of 2.53. This, alongside non-HLA matched sibling donor, were risk factors for non-relapse mortality in multivariate analysis. Independent of involvement of other organ sites, liver involvement was predictive of poor outcomes. And liver involvement was also associated with steroid refractoriness, with most of the patients, about 72%, deemed so. This would be consistent with what we would expect anecdotally, that's from clinical practice, from what we see of the grade 3 through 4 acute GVHD patients, even in our current practice. So what is liver to acute GVHD, though, is not the same for liver and chronic GVHD. In a retrospective analysis of 249 patients with post-transplant liver dysfunction, this was all done at the Karmanos Cancer Institute in Detroit. Those with overall grade 3 through 4 acute GVHD had significantly worse overall survival, worse non-relapse mortality, and worse relapse-free survival with liver involvement. In chronic graft versus host disease, liver involvement was associated with worse non-relapse mortality, but not with overall survival and not with relapse-free survival. This is important because we've repeatedly heard that liver GVHD imparts worse prognosis and poor outcomes for all transplants, but there's an important distinction that you have to make, whether it's acute or chronic, and then maybe even whether it's hepatic versus classic variant as well. So this is important because liver involvement does not carry the same gravity and morbidity and mortality in chronic graft versus host disease that it does in acute GVHD, despite the claims as so. This doesn't make it less important, though, that there's liver involvement in chronic GVHD, right? So, but it might mean that maybe the liver involvement could still be maybe more treatment responses or more slowly progressive. Oops. So AST and ALT elevations, alkaline phosphatase, GGT, total bilirubin, even the lymphocyte infiltration and the fibrosis that we see on pathology, this does not always mean GVHD, though. And this is one of the major problems we run into when we see these patients in our clinics. The differential diagnosis for these liver abnormalities is very broad. And common mimics are drug-induced liver injury, infection, especially hepatitis B, hepatitis A, but also CMV or fungal infections. And these can be difficult to distinguish even with a biopsy because they can be very similar with the same lymphocytic infiltration. Other causes of these liver abnormalities may be veno-occlusive disease, sinusoidal obstructive syndrome, iron overload, which is completely overlooked in my opinion, cholestasis of sepsis, underlying malignancy recurrence, steatohepatitis and steatosis, and often these conditions may be simultaneous with a liver GVHD process. Rarely do we get a liver biopsy that only lists solely GVHD as a possible diagnosis. It's usually with a caveat that there's in the setting of significant amount of steatosis or a significant amount of steatohepatitis, thus further complicating the diagnosis of liver graft versus host disease. So it might then be surprising that obtaining a liver biopsy is more an exception than a rule. Despite its utility in helping us narrow or confirm the diagnosis, oftentimes obtaining a liver biopsy is deferred due to the perceived risk of bleeding or other complications. The patient might have a lower platelet count, and so we'd be more unwilling to proceed with a liver biopsy. An NIH cross-sectional study published last year looking at 315 patients, diagnosed patients with clinical liver GVHD based off laboratories alone, using ALT or T-bilirubin that are greater than 3 times upper limit of normal, with no other explanation, that had no other explanation for their liver abnormalities, resulted in 50% of these patients with a clinical diagnosis of liver GVHD. That would be roughly 150 to 160 of those patients, right? But only 32 had a liver biopsy that they were able to evaluate. And this actually included some liver tissue that was available through autopsies. Only 27 of those, unfortunately, were evaluable of the 32. But even so, what are we seeing from those 32? What they found was actually only 59% of those samples were actually liver GVHD, and 41% of them had no liver GVHD. So it goes to the point of we really need to obtain biopsies. What we think is liver GVHD half the time is not actually liver GVHD. You can see how this has major implications. Patients are on treatment with immunosuppressive therapies when they might not actually need it. Or maybe they have an underlying condition that's being ignored or is going unrecognized because we haven't taken the time or taken the extra step to do the liver biopsy or taken that extra risk. So there is, of course, the caveat that the biopsy is not always 100% diagnostic either. So that's what you have to do in terms of counseling the patient, is putting them through the risk is we might not get the answers we're hoping for. But without any pathognomonic features for liver GVHD and also the dynamic effects of treatment, the clinical presentation and biopsy have to be used in tandem. So this study went further and analyzed the association of alkaline phosphatase, total cholesterol, and LDL, among others, with biopsy proven liver GVHD versus not. They found that alkaline phosphatase and total cholesterol increased the sensitivity of diagnosis of the clinical liver GVHD. And these results, though, are unfortunately based off a small number of patients ultimately. So since they're limited by the small number of biopsies, but you can see how this could be very helpful information if we were more broadly obtaining liver biopsies. When comparing the sensitivity, specificity, positive predictive value, and negative predictive value of the NIH consensus criteria alone versus with the addition of total cholesterol, there was a modest improvement of sensitivity and positive predictive value with doing so. There's certainly room for improvement, even with these small modifications we can do with the laboratories. So I thought that was really helpful for that to come out of that NIH research project. So in a study with a greater number of biopsies then, obtained at a single center, 112 liver biopsies in 100 patients were reviewed. Most of these biopsies were transjugular, and importantly, out of the 112, there were only 3 complications with either a hematoma or pneumothorax. There were no mortalities. 80 of the 112 biopsies were consistent with graft versus host disease, 11 with iron overload, 7 with non-alcoholic steatohepatitis, 5 with non-viral hepatitis, 3 with VOD-SOS, 5 with cholestasis, 1 viral hepatitis. The diagnosis preceding the biopsy was correct in only 49% of the cases, similar to what they were seeing in the NIH consensus, in the NIH paper, which we just talked about. And in 49% of cases, the biopsy itself led to a change in treatment. This meant treatment escalation in 14 patients and discontinuation in 4. It's an example of several such published reports, multiple out there, regarding the utility of the liver biopsy. And like the NIH cross-sectional study, biopsy have reportedly led to changes in treatment in 31 to 95% of cases. I think it really more falls to closely around 50%, but that means that at least 1 in 3 patients may benefit from referring the diagnosis of their liver dysfunction with a biopsy alone. Of course, we also have to consider the opposite, that the biopsies could also be misleading. While this report is from 1974, the diagnostic tools for the liver GVHD have not actually changed, right? So this remains applicable. The University of Minnesota reported results of liver biopsies performed in BMT and non-BMT patients, and they reviewed them blindly. They described the number of false negatives and false positives. Of 27 BMT biopsies, 9 were negative for GVHD, and upon further cross-examination, 1 of the 9 was deemed falsely negative. Not bad. Of 57 non-BMT patients, 9 were deemed consistent with GVHD. That means 15% of patients who had never received a stem cell transplant were deemed to have GVHD. This demonstrates the number of mimics or confounders on biopsies and should give us all pause, right, to consider a broad differential diagnosis for every liver dysfunction. The table that's shown here, grainy because it's from 1980, that lists the corrected diagnosis. Most of them chronic active hepatitis, which is AH, chronic persistent hepatitis, CPH, extrahepatic biliary obstruction, and orthotopic liver transplantation. So in all fairness, conditions that very much look similar with an acute hepatitis picture, which may be very misleading if there's a history of bone marrow transplant prior. And again, these were blindly done. So similarly, in an autopsy study of 37 BMT patients, also from the NIH, and despite clinical suspicion of GVHD, only 13 out of 15 samples were consistent with liver GVHD. And those not suspected of liver GVHD, 7 out of 22 did have pathology consistent with possible liver GVHD. Thus, comparing clinical suspicion, which could have included biopsies while alive or of other tissues, to autopsy results, sensitivity of clinical suspicion was 22%, specificity 54%, positive predictive value 13%, and negative predictive value 68%. If you add in a calculated ratio of ALT and alkaline phosphatase, then you can increase the predictability. It's also important to note that timing the liver biopsy may impact its utility. Obtaining it too soon may lead to a false negative before significant changes can actually be detected on the pathology. Or if a patient is on treatment, you have to keep this in mind. This may affect the sensitivity of your results because you've now had response. So you might not be able to diagnose GVHD as effectively, though conversely, if done serially, which has not been studied, may allow you to actually monitor treatment response by biopsy. And I will say that we do this in our practice at OSU. So in further consideration should be given to the safety of obtaining biopsies. So I did want to highlight this. So particularly transjugular liver biopsies, though actually percutaneous biopsies are remarkably safe, surprisingly. In a large study of 1,300 patients with non-targeted liver biopsies, these are not transplant patients, no adverse events were reported in 92% of patients. The vast majority of the reported adverse events were pain. And this was, more common in percutaneous, as you might expect, over transjugular. Only 0.4% of patients had a small hematoma at needle entry site. And bleeding requiring a transfusion was reported in 2 out of 1,300 patients. So overall, for a non-BMT patient, very safe. And if you're transfusing a BMT patient to have a platelet count sufficient, giving them FFP if you need to, this should be a very safe procedure to do. In a BMT-specific cohort, the previously mentioned 112 patients with mostly transjugular biopsies, again, only 3 of them had complications. So we can reassure our patients that obtaining a liver biopsy, which has a roughly 50% of changing their management, is safe. This is also important because we have very limited other options to help us with the diagnosis. Investigators have previously tried to look at plasma biomarkers for diagnosis of GVHD, and while there is notably higher expression of certain biomarkers over no GVHD, like Reg3 alpha, hepatocyte growth factor, KRT18, which is a cytokine fragment, an apoptotic protein, in liver GVHD patient samples versus no GVHD, there's a difference. But in those with liver GVHD versus other liver dysfunction, there's no difference there as opposed to with no GVHD. So if there's liver dysfunction, it doesn't help differentiate the diagnosis. Though new imaging techniques do exist, and they have potentially some promise. This is a very small pilot study looking at shear wave elastography. This was done out of the University of Michigan, Ken, where they had 6 patients with chronic GVHD versus 10 patients that were just in their database, had no history of bone marrow transplant or liver dysfunction. The ultrasonographers at University of Michigan preliminarily reported a difference in shear wave velocity in chronic liver GVHD patients. These patients had hyperbilirubinemia, elevated transaminases, and/or abdominal pain. So we don't know how to correlate how advanced the liver involvement might be in these cases to know how much this actually correlates and how early of a predictive tool it could be. But it's certainly interesting to know that it exists and has potential. So treatment, while there is no specific treatment for liver GVHD, currently FDA-approved agents, ruxolitinib and belumosudil, have reported organ-specific response rates. Ruxolitinib was studied in a phase 3 trial comparing it to best available therapy and had an overall response rate as shown for the best available therapies roughly ranging 20 to 30%. Ruxolitinib specifically in the liver, though, did not show much improvement over best available therapy. Though you have to keep in mind that the study was not powered to evaluate this organ specifically. So, but I do anecdotally feel that this is also low compared to what we've experienced in real life. But compared to best available therapy versus ruxolitinib, there's 21 versus 24% organ responsiveness with ruxolitinib. With belumosudil, results were similarly shown in the Rockstar study. This is a phase 2 study, and so did not have the comparator arm that ruxolitinib and REACH3 did. And while other organ systems did have higher overall response rates, the liver did show a roughly 39% overall response rate. And notably, the liver does seem to have more capacity to have a complete response, mostly because we see normalization of the liver enzymes, right? So a 31% complete response with an 8% partial response. The potential future therapies might be axatilimab, which is an anti-CSF1R antibody, which I think we'll be learning about more in the future, has a macrophage target, but then probably also affects fibrosis. So may be more helpful, particularly in advanced liver disease or liver GVHD. And in the preliminary results, the overall response rate was 74% in refractory chronic GVHD after 2 or more prior lines of therapy. So patients that have failed ruxolitinib or failed belumosudil with chronic liver GVHD can actually still have a potential third-line agent or next-line agent. We are waiting, though, for the release of the organ-specific responses, and we'll see what the liver-specific response is there. So in rare cases, liver transplantation after bone marrow transplantation has been performed for liver GVHD. They've used living donors, partial livers, deceased donors, and had success. So when you search the Organ Procurement and Transplant Network database from 1988 to 2003, you see a total of 73 patients who have actually undergone liver transplantation for severe liver GVHD. And they could be from a bone marrow transplant or other non-liver organ. And the cumulative 1-year post-liver transplant survival is actually 76%. So the retransplantation rate is also very low at only 5.4%. So, and none of the deaths were attributable to recurrence of the liver GVHD or due to graft rejection. So it's, in a very rare case, possible also to proceed with a liver transplant. So as key takeaways from this, I wanted to impart that there are 2 variants of liver GVHD, hepatic and classic, and it's important to sort of in our minds start wondering how they will be and if they are different and responsive to therapy. There's also the fact that liver involvement in acute GVHD portends worse overall survival, non-relapse mortality, and relapse-free survival. And liver involvement in chronic GVHD increases non-relapse mortality, but not overall survival. Importantly, 31 to 95% of the time, a liver biopsy again changes treatment. And that is the most key part of, I think, this presentation, is that what we assume is liver GVHD is not always liver GVHD, and half the time is not, from what we've seen from studies. And we should pursue a liver biopsy because it's safe and it's crucial for the accurate management of these patients. As what we've seen, this is a multidisciplinary coordination of care between the pathologist, between the hepatologist, between the bone marrow transplant physician, between the interventional radiologist performing the biopsy. So it's what we've definitely seen in our practice, that multidisciplinary coordination enhances the patient's care and can lead to faster treatment. So since we do have a minute, I did want to go through a case presentation because something separate from those bar graphs and the charts. I wanted to go over a case presentation that actually our nurse practitioner within the OSU GVHD clinic has submitted to Tandem as well. We have a patient who had for years been dealing with gastric antral vascular ectasia. And so this is where you'll have oozing, essentially, or called watermelon stomach. You'll have oozing from usually the antrum of the stomach. And so this patient was receiving repeat endoscopies every 2 to 4 weeks, getting banding, getting argon, getting cryotherapy repeatedly, and getting transfusions to make up for this. And this is one of her many endoscopies, actually. Oh, sorry, you're not seeing that here. This is one of many endoscopies that she had, where you could see oozing and the cryotherapy images that they took. So she was eventually referred to a surgeon to consider antrectomy, because in very refractory cases of GAV or GAVE, patients will actually only benefit from finally actually having removal of and having antrectomy. So in that process, the surgeon ordered a CT scan of her abdomen, and the abdomen showed that she actually had liver cirrhosis, even though she had normal liver enzymes and no other no laboratory values that were consistent with having cirrhosis. She seemed to have cirrhosis based off of CT imaging with the contour of her liver capsule. So after this, there was some concern for liver cirrhosis, and so then at that point, she was referred to the GVHD clinic, and what we asked for additional biopsies based off of her liver biopsies to evaluate further whether this was actually liver GVHD this whole time. So they eventually did FISH for XY because she had a male donor, and they also did additional staining to see what composed the lymphocyte infiltrate, and found that it was very CD8 mediated, which would all be consistent with the liver GVHD diagnosis. And so what you'll see here is actually the first ABCD images are from, and she had significant fibrosis consistent with the cirrhosis. The ABCD images were from prior to treatment, and the below images are from with treatment. So once we saw her and did autoimmune hepatitis panel, and everything came back negative, but seemed consistent with liver GVHD, we started her on ruxolitinib with improvement on repeat liver biopsy after just 3 to 4 months. And this actually is a graph put together of her blood transfusion requirements and her hemoglobin trend over time. So in the far left, you see the date of transplant. So after transplant, initially, that first hospitalization, she's requiring blood transfusions, of course, during her nadir, and then she recovers quite nicely. Then when she's eventually diagnosed with GAVE, her hemoglobin, you see, it has been dropping, and it fluctuates, repeatedly getting multiple transfusions in single days, repeatedly over several months. And then finally, after we considered the diagnosis of liver GVHD, we started her on ruxolitinib, and she's actually completely transfusion free as of the last 3 months. So I attribute this to the work that comes from working with multiple consultants in person and on-site with dermatology, physical therapy, occupational therapy, clinical research coordinators, as well as a close collaboration with the nurse practitioner and our nurses in the clinic. And I'm very proud to be working with this group of people. And so with that, being able to make a difference like that, for example, for that liver GVHD patient, has been really rewarding. We also have consultants off-site with ophthalmology, pulmonary, and coordination of care with other subspecialties. And again, this elevates the level of patient care that we're able to provide. So with that, I want to say thank you very much for your attention. I'll take any questions.
Terrific job. I think this was so clinically relevant and practical. In my own clinical experience in seeing patients and managing them, I think the big issues with liver GVHD fall into three big clumps. It's if you have skin and gut and some increased bilirubin, I think it's easier for people to say, that's liver GVHD, we're going to treat it. What's worse or more challenging is when it's liver alone and you don't have an increase in bilirubin, you just have these high spikes in AST and ALT. Or perhaps even more challenging is when you're treating someone who may have multivisceral GVHD, the other skin and gut are improving, but the liver enzymes still are not. And then the question is there something else going on in the liver? Is it refractory liver graft versus host disease? All of these things, including the differential diagnosis, I think points to biopsying. How many people, show of hands, regularly biopsy patients who have liver dysfunction? I mean, I think we're a little bit, it's interesting, Steve, you make yeah, we should be doing this, but I can tell you, I'm not sure that's the case in internal medicine. I'm telling you it's not the case at Hopkins, but on the pediatric side, we actually do this all the time. In kids, if you happen to have a skilled interventional radiologist, if the patient's big enough, you can do transjugular. We've actually had excellent success in laparoscopic biopsies, particularly in those patients who are coagulopathic, neutropenic, thrombocytopenic, et cetera. And it also allows you to get a good core and even a wedge. So you get really good tissue, which I think could be a limitation in some of the transjugular biopsies. So this was really illuminating. I think everyone needs to understand that this is a problem. We need to be able to go after this to make the diagnosis. I'm going to pose the first question to Steve, because I think in this context, you're the GVHD expert, right? Chronic GVHD expert. What are the challenges, I think, in diagnosing liver when there is no increase in bilirubin? So the staging and the grading is predicated, at least traditionally, on bilirubin. So there's many of our patients who don't have hyperbilirubinemia. On biopsy, they do have inflammation in the portal triad. They have bile duct destruction, ductopenia, et cetera, all consistent with GVHD histopathologically, but then we're challenged with how best to grade and stage. So I could open up to Steve, or how do you guys approach that when you're trying to stage and grade? Maybe someone's on a clinical trial, maybe they're not. You're getting your APPs to grade your GVHD, whether it's acute or chronic. How do you overcome some of those challenges?
So we follow the biopsy. We prioritize the biopsy regardless of what the laboratories are showing at that point. I mean, if you have a liver biopsy that's very consistent with ductopenia, with the cholestasis, and surprisingly, you're not seeing that for whatever reason in your laboratories, then we will still treat. And then that's how we follow, is also actually by serially biopsying with the liver biopsy as well, to make sure that we're seeing improvement with therapy. So we'll space about usually 3 to 4 months to repeat a liver biopsy.
Yep. But how do you stage it? How do you clinically stage acute GVHD of the liver without hyperbilirubinemia? Re-educate us.
Well, this is probably not acute, right? So, I mean, it could be. It's that's why I sort of presented as hepatitic versus classic, because I don't know that the acute versus the chronic actually is as clearly defined as we would hope it to be. So, at that point, these patients are usually more chronic presentations with that. They have that more cholestatic picture. So at that point, we're considering them, moderate to severe chronic GVHD based off of professional opinion at that point. But yeah, no, this is the problem with the NIH, the grading system for chronic GVHD in particular, right? Is that it's limited to be able to individualize it to the different manifestations of it.
Well, great presentation on very difficult topic, so really congrats here. Well, what we have is acute and chronic, right? For chronic, we know there are really no diagnostic criteria for the liver GVHD unless you have some other diagnostic presentation. And that's about it. You have to have a level of suspicion in the context. Otherwise, you can't say it's a chronic of the liver per NIH criteria. For the scoring severity, actually, alkaline phosphatase, transaminase are part of the NIH severity scoring system is currently. For acute, I really don't recall where it stays. How do we grade patients that have only transaminase without bilirubin? I think they're sort of like a still blind spot in our reporting. And it's like very critical, I think, what you mentioned, that we should be very carefully, probably serially following and more aggressively, because you showed that acute GVHD of the liver affects survival. And there's so many other, if I learn anything from doing this, it's just the differential diagnosis is huge. So you treat immunosuppression, you don't treat, but there are many other things, and that affects the drugs metabolism, all kind of things. So often when I see these delays and kind of, second guessing when you have this early increase in transaminase, usually around 6 months when you taper immunosuppression, and I do biopsy. Oh, it's looks like a drug, induced, and like, oh, we'll wait, and then like 2 weeks after, patient has bilirubin of 5, So I think the main message is, we just need to be more assertive in doing these biopsies and working with hepatologists, and it's nothing is risk-free, but it's. It seems like we just need to be more assertive on that.
Thanks, Steve. Other questions?
Julie Boyko, Fred Hutch. Great talk, great topic, and this resonates with a difficult case that I dealt with recently. I have a question about acute liver GVHD that's twofold. First of all, when you have liver GVHD, and just for sake of argument, let's say it is a cholestatic acute GVHD picture, what natural history do you prefer for seeing, or length of time do you prefer to see if your immunosuppression is working? I have seen bilirubins continue to rise, albeit maybe not as extreme of a rate of rise as prior to treatment. And it's challenging to know, is the immunosuppression working and this is just taking a while to turn around? Or do you need to jump ship to something else? And then my follow-up question is, what is your choice of agent, after the patient has failed steroids, failed ruxolitinib, you've optimized the calcineurin inhibitor, what's your next go-to agent?
Yeah, so they're really good questions. And we've certainly seen, for example, hyperbilirubinemia without any other transaminase elevations, and just been watching the bilirubin go while we're waiting for therapy. So I've been very much in the same boat as you with certain cases. And unfortunately, those are extremely refractory cases, right? As the data showed, once you have liver involvement, you're already grade 3 through 4. Those patients have a very high risk of mortality in acute liver GVHD or acute GVHD. So in terms of tolerance or patients, we're monitoring those patients every single day inpatient, right? These are not outpatient clinic visits. This is maybe checking liver enzymes twice a day, checking liver function, checking albumin, et cetera, checking coags, not just looking at alkaline phosphatase or GGT and T-bill anymore, because we're really looking at the whole liver in general. But low threshold to be more aggressive, because we know those patients are so refractory. In terms of what actually works, there's not enough cases to tell us, and there's not enough data to tell us what's going to work specifically for liver GVHD. So the pathophysiology for liver GVHD is there's very little research about specifically liver. There's a couple of papers about, being Th17 mediating, having IL-17, but we don't have a target for those drugs necessarily that's going to make a difference for liver GVHD. So being more aggressive, whether it's giving less time on ruxolitinib to fail or considering giving, an off-label medication, and giving higher dose steroids for longer, there's no perfect way. There's no good answer to that question. And unfortunately, we have, when I think about that question triggers, unfortunately, memories of patients that we've lost, right? Because they have been so refractory to treatment. But we throw everything at them, ECP, giving them multiple lines of therapy in quick succession to try to get control of it.
We are bumped up on a break, so maybe one last question.
Thanks, Ken. Hannah, like Ken, another University of Michigan person. So, Pavan Reddy is now at Baylor. Recent mirroring studies that Pavan has published show that GI iron content can greatly impact the development of GVHD. And that chelation, at least in this mirroring model, can greatly abrogate the development of GVHD. You wonder how that translates to hepatic iron content. And do you know of any studies that have been published that looked at baseline hepatic iron content or even serum ferritin levels baseline and the subsequent incidence of hepatic GVHD, acute or chronic? I don't.
I don't, not specifically to liver GVHD. There's obviously the publications with ferritin pre-transplant and how that portends worse prognosis post-transplant in terms of non-relapse mortality. And that might be an indirect reflection then of iron overload, and leading into stem cell transplant that then increases the risk post-transplant. But anecdotally, I've seen patients respond with liver GVHD who had iron overload to iron chelation as well. So, this is very anecdotal in my personal experience, but I am not surprised, I wouldn't be surprised if we were able to do a study and actually put iron chelation as forefront to see how it would improve liver inflammation and liver GVHD as well.
A great presentation, great discussion. We have a break until 10:05 for the next presentation. So try to make it back in, get a cup of coffee and